Welcome to the American Osteopathic Association audio educational service for January 1976. Brought to you by SK&F Company, division of SmithKline Corporation. Our topic for this month is myocardial infarction, a practical approach to treatment. Our speaker is Carl M. Pesta D.O., chairman of the Departments of Internal Medicine and Nuclear Medicine at Harrison Community Hospital, Mount Clemens, Michigan, and attending and consulting physician and co-chairman of the CCU at Mount Clemens General Hospital. A self-assessment test, which may be filled out and sent in for CME credit, along with visual aids to this tape, appear on pages 121, 122, 124, and 125 of the January Journal. And now, Dr. Pesta.
Acute myocardial infarction. These very words are enough to strike fear and terror in the hearts of the general population, and rightly so. Acute myocardial infarction ranks first as the cause of death of patients under 65 years of age. According to current statistics, 600,000 patients will die of acute myocardial infarction in 1976. Two-thirds of these deaths will occur outside the hospital, and one-half of these deaths will occur suddenly and unexpectedly, usually within 2 hours after the onset of symptoms. 2 hours is very important. Those patients who received care within 2 hours had a markedly decreased death rate than those who received care after 2 hours. From these statistics, you can see that community involvement and community education are very important. As physicians, we must make the general public aware of the risks of myocardial infarction. These risks are obesity, diabetes, smoking, hyperuricemia, according to the Framingham study, and possibly hypertension. I say possibly because, as you are aware, some of the recent articles have had difficulty in determining a direct causal effect between hypertension and myocardial infarction. However, it has been shown that those patients who have adequate control of hypertension after their myocardial infarction have a much better survival time. Obviously, we must encourage our patients to lose weight, to control their diabetes, to discontinue their smoking, and to control the hyperuricemia. Many risks are present in the patient with heart attack, both from the reaction of the physician and the reaction of the patient to his symptoms. Many times the patients lack the current information needed. There is the classic fear and denial, the misrepresentation of symptoms, thinking, oh, this is just indigestion, heartburn, reluctance to notify the doctor or the patient's relatives. We must not forget that this first 2 hours are very important. Therefore, we should make available to the public warning signs that they may use to help save their own life. The facts that should be presented to the public are printed in the Journal of the American Osteopathic Association, and they are headed by heart attack. These facts could save your life. It's also important that community education involve the necessary civic materials to increase funds needed for EMTs, mobile coronary units, etc. We also must educate our high-risk patients. We must educate them as to the possibility of recurrent heart attack, and we may even encourage them to self-administer drugs. We will speak more about this in a few moments. Once the patient reaches the hospital, a very critical phase occurs. As mentioned, 2 hours is very critical, and the care must start immediately in the emergency room. When the patient arrives at the hospital, we must be careful to set up a certain type of priority so that precious minutes are not lost. We must instruct our nurses that chest pain is heart attack until proven otherwise. Above all, the patient must not be lost in the myriad ways in the emergency room. Routinely, the patients are subjected to the historical information, physical examination, and then the studies including electrocardiography and diagnostic enzymes along with blood pressure monitoring. It is very important in the historical information obtained from the patient that we determine the type, duration, and radiation of his pain. The patients with heart attack pain are very characteristic. Many times they will squeeze their fist in front of their chest as if to tell you that they have a squeezing type of pressure on the heart. They will tell you where the pain radiates. Usually the pain will radiate into the left arm. It can radiate down into the right arm. Many times it will radiate up into the teeth. It is almost never sharp and stabbing. Many times I'm sent patients from referring physicians with a sharp and stabbing type chest pain, and the pain can be reproduced upon pressure on the chest wall. Many times this represents a type of costochondritis, and many patients who thought they were undergoing heart attack turned out to have a type of Tsetse syndrome or the classic costochondritis. A word about the pain. Pain of acute myocardial infarction usually abates in 2 to 3 hours. My colleagues and I have long commented on the fact that we would much rather take care of a patient who has a sudden bout of severe chest pain lasting about 2 to 3 hours than subsides than to take care of the patient with minor episodes of pain which continue over the next 2 days. These minor episodes of recurrent and not so minor episodes of recurrent pain many times reflect progression of the myocardial infarction. May I impress upon you, however, if clinically you suspect a myocardial infarction and your electrocardiograms and enzymes are within normal limits, do not discharge this patient. These patients should be kept in some type of observation area and monitored because, as you're aware, many times the signs of acute myocardial infarction do not occur for approximately 24 to 48 hours. If you will ask your patients with acute heart attack about premonitory signs, you will be amazed to find that almost 100% of these patients will have had certain premonitory signs for up to 2 weeks prior to their acute episode.
Dr. Pesta will continue after this word from SK&F Company.
Listen for a moment with the ear of a patient hearing a reasonable diuretic regimen.
Now, I want you to take this medication twice a day after meals. It will get the excess water out. And this prescription is for a potassium supplement. Mix it in water and take it 4 times a day. Add a couple of bananas or oranges to your daily diet, too.
Not at all difficult to say, but it is taking medication 6 times every day. And have you ever tasted the potassium supplements? Aside from the fact that the regimen involves instructing the patient to increase fluid intake, at the same time you're prescribing a diuretic to reduce fluid volume. In comparison, consider this.
I want you to take this medication twice a day after meals. It will get the excess water out.
If you found that 50 milligrams of triamterene given with 25 milligrams of hydrochlorothiazide gives you the diuretic effect the patient needs and still avoids the excess loss of potassium so often a result of treatment with thiazides or superpotent diuretics, it makes sense to prescribe Diazide. It makes sense from the standpoint of the patient's convenience and comfort. And it makes sense when considering the patient's budget, too. Add the cost of potassium supplements to the lowest priced thiazide, and you'll see what we mean. The price of that extra fruit in the daily diet adds up, too. Direnium makes the difference in Diazide. Besides its additive diuretic effect, direnium blocks or reduces the potassium-wasting characteristic of hydrochlorothiazide. There's rarely a problem with hypokalemia in Diazide therapy, and no risk of hormonal side effects. Elevated serum potassium levels can occur, of course, with any potassium-conserving agent, but it is rare when urinary output is adequate. Still, BUN and serum potassium should be checked periodically, and any potassium supplements you might have been giving should be discontinued. They shouldn't be reinstituted unless hypokalemia develops or dietary potassium intake is markedly impaired. Even then, the potassium level should be monitored closely. Please consult your PDR or the prescribing booklet accompanying this tape for contraindications, other warnings, precautions, and adverse reactions.
In the physical examination of the patient with myocardial infarction, obviously careful auscultation of the heart is necessary, auscultation of the lungs, but may I remind you that God gave us hands before He gave us a stethoscope. Do not forget to palpate the chest. Palpate for parasternal heaves. Palpate for double apical thrusts, things that will tip you off that something is occurring in the myocardial action. After the physical examination and historical information have been gathered, we then depend on our laboratory values. We can do recently enzymes that will tell us if there has been any myocardial necrosis or any type of involvement of the myocardium. Our classic enzymes have been the CPK, creatine phosphokinase, the SGOT, serum glutamic oxaloacetic transaminase, and lactic dehydrogenase, or LDH. Most recently, we have been able to perform the CPK isoenzymes. As you are aware, many causes are present for a rise in total CPK. These include disease of the heart, disease of the neurological system, diseases of skeletal muscle, diseases of the thyroid, and other miscellaneous illnesses. Therefore, it is important to differentiate between these utilizing CPK isoenzymes. The main advantage of CPK isoenzymes is in identifying the cause of CPK elevation in patients who have had chest pain or intramuscular injections. The normal CPK rises within 6 to 8 hours, rises to its peak within 24 hours, and usually is within normal limits between 24 to 72 hours. The CPK MB, which we will speak of in a moment, is elevated for only 30 hours as opposed to the CPK. We speak of 3 CPK isoenzymes, and if you will remember this, if we start at the head, decreasing down the body, the CPK1, which is called BB, is found in the brain. CPK2, which is CPK-MB, is found almost exclusively in the heart, but may be elevated in muscular dystrophy and dermatomyositis. CPK3 is MM, found in skeletal muscle, and this is the most common type of CPK. If we have a patient who has elevated CPK and the CPK-MB is elevated, this is a sign of myocardial necrosis. However, if we have a patient with a normal CPK with an elevated CPK-MB within this CPK, this also is a sign that myocardial damage has occurred. Therefore, you can see that CPK-MB is our currently most sensitive indicator of myocardial damage. In the past, the SGOT, or serum glutamic oxaloacetic transaminase, was useful, but as you are aware, this is also found in many other types of illnesses, including hepatic congestion, congestive heart failure, liver disease, birth control pills, muscle diseases, shock, etc., that this has not been utilized as much and in essence has fallen into disrepute. The SGOT, however, rises in 8 to 12 hours, peaks in 18 to 36 hours, and is gone within 3 to 4 days. The lactic dehydrogenase, or LDH, has been useful, but once again, this is a very nonspecific type of enzyme test. Can be found in liver disease, renal disease, carcinoma, pulmonary embolus, and even in the very act of venipuncture. It rises in 24 hours, peaks in 3 to 6 days, and stays with the body up to 14 days. Of more benefit recently is the use of LDH isoenzymes. These are numbered 1 to 5. Many times in some of the articles, I have found the numbering to be from 1 to 5 and then from 5 to 1. If you can remember that the fast-moving isoenzymes represent the heart, the slow-moving isoenzymes usually reflect the liver. HBD was used in the past. This is the heat-stable type of the LDH isoenzymes, but currently with the CPK, this is not specifically necessary. A word about the electrocardiograms in the diagnosis of myocardial infarction. We are all familiar with the classic fireman's hat of acute myocardial infarction, but let me caution you to always be suspicious of terminal T-wave inversion. With terminal T-wave inversion, this always means that something is going on in the heart, and a very high index of suspicion must be present in this type of patients. Do not forget also that the patient may very rapidly pass from the normal EKG to the acute ST segment injury pattern to the Q wave with inverted T wave, many times even before entering your emergency room. So if you have a high clinical index of suspicion, the cardiac signs on the electrocardiogram look to be ancient, use your index of suspicion and observe this patient. A pearl regarding electrocardiograms, we're all aware of the anterior myocardial infarction, the inferior myocardial infarction, which is sometimes wrongly called posterior infarction. But let me tell you that also true posterior myocardial infarctions do exist. These occur on the true posterior wall of the heart, give reciprocal changes on the anterior wall of the heart, and what we look for is the mirror image on the anterior strip of the electrocardiogram. This can be viewed by utilizing a mirror or simply by taking the strip, placing it up to a light, turning it upside down, and viewing the tracing from the back against the high-intensity light, and you will see the classic fireman's hat pattern if this is present. Vectorcardiographic changes are beyond the scope of our discussion today, but they may not be superior to the 12-lead electrocardiogram in the diagnosis of acute myocardial infarction.
Dr. Pesta will continue on side 2. Please reverse your cassette.